I hope things are okay in Delhi, Gurinder.
Doing well, boss. Doing well. I'm a positive patient right now, so I'm just isolating myself. But the
Yeah,
other guys are doing quite well. We got a huge numbers. We're collecting a hell of a lot of data and experience from this.
I hope you are asymptomatic.
Pretty much.
So that's good to know.
But take care, huh, Gurinder.
Thanks, boss. Thanks.
Yeah, take care.
Okay.
Okay, Ashok.
Good afternoon, everybody. We are live now. We can start. Over to you, sir.
Okay, thank you, Ashok. I welcome all of you to the Arthroplasty Conclave. And we had a small Diwali break. And we are all back now with a very interesting topic, which is periprosthetic fractures and the challenges which we all face. We have two excellent speakers who are vastly experienced, and both of them work in the UK. And it's really a pleasure to always have them in the conclave because we learn a lot from the cases, the discussions which follow. And the first speaker is Dr. Sanchit Mehendale, and he's going to talk on the tips and tricks and the challenges in periprosthetic fractures. And following that, Dr. Nikhil Shah, also from the UK, will show some cases. And knowing Nikhil, his cases are well worth seeing and absorbing and learning. So all of us face this issue because our patients are getting older. Our patients are getting joint replacements by experienced surgeons. And when the joints last well, but the patients fall and break their bones, the challenges which ensue are something which all of us should be aware of, and we should know the tricks, all the tips we should learn from these masters. And I will hand it over to Dr. Sanchit Mehendale for his first talk. Dr. Sanchit, you can share your screen.
Good afternoon, everyone. Thank you, Kiran. Okay, so we'll start with the challenges in periprosthetic fractures. We will go through the background and the problem. We'll look at the classification and then talk about the solutions. And in the solutions, what I'd like to mention is the personality of the fracture. Now, that's as applicable in periprosthetic fractures as it is during any other sort of native bone fracture. We'll talk a bit about the multidisciplinary team structure, which is slightly different to what you would have back home, where we can occasionally work in silos, but certainly, and then we'll go through a few cases and analysis, and then Nikhil will sort of complement that with his cases. So the nature of the problem, this is National Joint Registry data from 2019 in the UK. So nearly 95,000 primary joint replacements and 103,000 knee replacements. And this number is pretty static at the moment, but if you imagine these many patients going around with primary joint replacements every year and people living longer and longer, the next problem that we are going to have is of periprosthetic and interprosthetic fractures. So the incidence of periprosthetic fractures, this is old data, okay, from 1979 to 2000. But even then, the incidence of periprosthetic fractures was creeping up. So if we identify the problem, this is Mayo Clinic registry data. After primary joint replacement, the incidence is about 1%. And after revision surgery, it goes up to 4%. Okay, but this incidence varies hugely between about 4% and 20%. As we increase the number of primaries, as we are under more and more pressure to not see the patients in the follow-up period, we are likely to miss the osteolytic defects that appear over time. And in those situations, lead to a periprosthetic fracture, which then presents as a big problem to our sort of emergency departments. So again, National Joint Registry data in 2020, and you see the huge burden of periprosthetic fractures there. Okay, so 5,800 numbers for single stage revisions. Okay, and the incidence can vary hugely. This is the third commonest cause for revision of any type, okay, in the UK. So it's increasing burden of work. There is sparse evidence in the literature on the functional outcomes. So because you won't have massive series of these, the Vancouver philosophy is the most dominant philosophy that is still prevalent now. But most of the studies talk about the older implants. Okay, so the plating systems and things like that are a lot older. With the newer locking plates, sometimes you think that it might be more amenable to fixation rather than revision. And then the interprosthetic fractures. That's a sort of a separate problem. We have quite a few patients who have a hip replacement above, a revision knee prosthesis below, and then the bone fractures in the middle. And that's the difficult scenario. What do you do? Because you don't really have options of revising it. You either have to revise it to a total femoral replacement or something like that, or fix it. And even then, fixation is fairly challenging. Okay, so again, Garelick's work on incidence and demographics of 1700 plus surgically treated around a primary hip prosthesis. And at that point, what they were conscious of is an increasing burden of a Vancouver type C fractures. So again, if you talk about either native fractures or interprosthetic fractures, that incidence was nearly about 37%. What was interesting was that most of their fractures were in cemented stems. Now that's slightly contrary to what we know about uncemented stems, but I think the pure and simple reason was that the Swedish registry is full of cemented. Their default setting is a cemented stem. So they had more number of cemented stems, hence they saw more fractures in the cemented stems, cemented stem patients. And then Masry and Duncan's work on periprosthetic fractures. This is the whole Vancouver philosophy. And you'll see a lot of our understanding of periprosthetic fractures comes from the Vancouver group. There are some risk factors that have been listed in the literature. Okay, so with regards to cemented stems, increasing age is a risk factor. Okay, the taper slip, polished taper slip design is interestingly greater than a composite beam, again, because the wedge is being driven down all the time. The short high offset stem with large heads, presumably because it's sort of working in a cantilever fashion, can lead to periprosthetic fractures. A cobalt chromium stem, again, is associated with more incidence of periprosthetic fractures. An ovaloid or round cross section can also be associated. And the cobalt chromium stems, especially used with low viscosity cement, can predispose to periprosthetic fractures. All these things are important, and it dictates the choice of the primary stem that we use. Obviously, you don't need to change massive amounts, but again, if you're using a cobalt chromium stem, it might be that medium viscosity cement is the way to go. For uncemented stems, a collarless stem, a non-grid blasted stem, and a triple tapered design have been predisposed to periprosthetic fractures. Now, there's not necessarily a cause-effect relationship, but the association is more. Now, it could just be, like I said earlier, that the number of stems of this type going in are more, hence the incidence of periprosthetic fractures is more. And when we talk about the classification, we talk about the femoral side and the acetabular side. Acetabular side, by and far, less common or less detected. Okay, and what is not often mentioned in these periprosthetic fractures is the intraoperative bit. So then we subclassify them into intraoperative and postoperative. On the acetabular side, you have the intraoperative classification, which is stable or unstable, and similarly in the postoperative phase, the stable or unstable. Okay. On the femoral side, it's slightly different. Okay, so you have the intraoperative fractures, type A to C, and it depends on where the fracture is, and we'll see the reasons for that. So the type A is a proximal metaphyseal fracture, type B is a diaphyseal fracture, and type C is distal to the stem. And already you can start to see that the classification itself guides the treatment. And then each category is divided into either perforation, a linear crack, or a complete fracture that is displaced. When you are treating these fractures, again, you talk about tumor timelines. Similarly, you talk about factors to consider in the treatment of these. And the first thing is the fracture location. So that's where your classification helps you. Then the next bit is stability of the implant and the fracture itself. What is the quality of the host bone? What is the patient physiology? Will they tolerate a long operation, or you need some like a quick fix to try and get the patient? Are they active, mobile, so that they need functional outcome is critical, or are they sort of bed and chair bound, in which case pain relief might be the primary goal? Surgeon experience obviously comes with it. So are you experienced in all the modalities for fixation as well as replacement? And then the inventory available to you. So do you have 2 or 3 options, or is it sort of one thing that is available in the setup? So when we talk about intraoperative fractures, this is the sort of rough algorithm that you could go by. So this depends on if the fracture is recognized intraoperatively. Okay. And like we saw A, B, and C, so the proximal metaphyseal side of things, so greater trochanteric fractures, if they're stable, then you just observe them. If they're unstable, there are quite a few claw fixation devices. Now, whether it's the Synthes one, the Smith & Nephew one, or the Zimmer claw plate, they're pretty good. In the past, we used to say that once the trochanters escaped, it's escaped. But now, there are good fixation devices that are available for the great trochanter. So it's worth having them on the shelf for if and when you have great trochanteric fractures. They tend to be more common in revision surgery. Great trochanteric fractures are uncommon in the primary scenario unless the anatomy is grossly altered. The more common ones are the proximal femoral ones. So typically when you're sort of trying to engage an uncemented stem around the lesser trochanter and you get a calcar split, if the prosthesis itself is stable, you can get away with cerclage. If the prosthesis is unstable, you get the cerclage fixation. If now you can restore a tube, then you can go up a size or sort of get a fit in. You could bail out to a cemented stem. Or if the fracture and the prosthesis still remain unstable, then you have to get distal fixation with the fully porous stem. With the distal femur, again, you have 2 variables. Is the stem stable? So it's well below the area, and you can put a cerclage, you can put a plate, depending on whether there's a knee replacement distally. If the stem is unstable, you have to bail out to a long stem. This is, again, like I said, this is based on the Vancouver philosophy. So you'll see that in the older papers and older classification systems, the allografts and strut grafts are mentioned quite frequently. Now, in most cases, you would replace that with a plate. What do you do when the fracture is not recognized? Again, then you have 4 scenarios where, depending on the fracture and implant stability, you would act on it. So if the fracture and implant appear to be stable on the sort of post-op x-rays, then you just protect it till you achieve union. If the fracture and implant are unstable, you have to revise it. If the fracture is unstable, but the implant itself is stable, and that you could imagine again, if the fracture is distal to the prosthesis, that could be a scenario, then you fix it. If the fracture is stable, but the implant is unstable, you have to revise it. And when you revise it, you either have to put a similar length, but in most cases, you have to bail out to a longer stem and supplement it with a plate fixation. For post-operative fractures, and for the purposes of the discussion, we'll not talk much about the acetabular fractures. Part of the problem being that acetabular exposure is limited. And so with certainly cemented cups, acetabular fractures are fairly rare. With uncemented cups, they tend to be common, but they are missed, and by and far, because they're in compression mode in most cases, you get away with it. And then the ones in the revision scenario where you have a situation wherein there is pelvic discontinuity, then you do end up in trouble. And I think that Nikhil has alluded to in his previous conclave talks. So the postoperative femoral classification, you have the A, B, and C, similar to what we described for the intraoperative fractures. So the C one is well below the stem. Okay. And that's, again, not such a big issue because by and far you will fix it. The type A is then divided into a greater trochanteric bit and the lesser trochanteric bit. So the AG and the AL. Okay. And then the B is the main category, which is mostly the contentious area. So the B is around or just below the stem. All these classification systems were devised initially for uncemented stems and had been then extended to be used for cemented ones. And therefore, there is an issue with sort of this fracture, even if it's just below the tip, but the cement is cracked, then it's a type B fracture rather than type C. And that the B classification system is further subdivided into either the stem being well fixed, that is the B1. B2 is where the stem is loose, but the bone stock is satisfactory. And then the B3 is that the implant is loose and the bone stock is quite poor. And we'll try and sort of go through this with a couple of cases. So original classification 1995, so pictorial representation of the same. So your great trochanteric fracture, lesser trochanteric fracture, then you have the type B fractures where the implant is stable, the implant is not stable, and the last one with implant being unstable and the bone stock being poor. So the type C fractures in a native scenario where there's no distal knee replacement are fairly straightforward. The problem starts arising when you have a knee replacement distally, and even further so if you have a revision knee implant distally. So how do we actually manage it according to the classification? So the lesser trochanteric and great trochanteric fractures, by and far, symptomatic treatment. Okay, like I said, for the great trochanteric fractures, you do have claw plates available now that are fairly good and reliable in their fixation. C classification, like I said, you ignore the implant and fix the fracture as you would normally fix any fracture, only altered by the fact that if there is a knee replacement distally. And then the B bit is the bit that we need to talk about. So if the implant is stable, you fix it with whatever you're comfortable with, plating system wise. A lot of the studies in the past have talked about strut grafts. We don't tend to use them, certainly in Bristol, we don't tend to use them nowadays, partly because we don't have them on the shelf, and B, they've been replaced with the modern locking plating systems. The loose stem, you have to revise it. Okay? So the B2, you could revise with a long stem, either cemented or cementless. By and far, with the B3 fractures, you either have to try and restore bone if the patient is young, or if the patient is not young, then you have to bypass it if you can. So we'll try and tease this through some of the cases. So case of a periprosthetic fracture in a revision scenario where in the past impaction grafting has been done. So that's the AP view, and that's the rest of the femur. And when confronted with this sort of scenario, these are the questions that I go through. Okay. So in the analysis of the fracture, you look at the type of the stem, you look at the type of the fracture itself, then you work out, is the prosthesis loose? Is there enough bone stock? Does the acetabulum need revising? And is there a prosthesis at the other end? Now, if you apply these questions to the existing fracture, the fracture is comminuted, the implant is loose. Because there has been impaction grafting of the stem in the past, that's why you see the proximal bone stock not being great. There is, looking at that, there is no distal knee replacement. Okay. Does the acetabulum need revising? Well, not really. There's not a lot of wear, so you don't need to necessarily revise the acetabulum unless you want to go for a larger head. So the options, depending on that, this would be a B2 stroke B3 fracture because the bone stock proximally is loose. So you could still fix the fracture if the patient did not, or sort of was comorbid. So you could put a long cemented stem and supplement it with a plate. You could go for a long uncemented stem and supplement with a plate, if necessary. You could use a strut graft. And then the discussion is between, do you use screws and cables? Does that give a better fixation? Or go with just screws? Okay. So on this occasion, what is key to remember is you have to have your plan A, like I said, plan B, plan C, and then a bailout option. Okay. So sometimes these fractures are quite deceptive and things can go wrong pretty quickly. So something like a tumor prosthesis on the shelf is always a good idea. We have found that in some periprosthetic fractures where the patient is going straight to sort of proximal femoral replacement, sometimes saves a lot of time and you can do a much quicker operation. So post-operatively, this is what we did. So we opted for a long uncemented stem. Okay. When you change your modality of fixation from cemented to uncemented, what you have to be is fairly meticulous about taking all the cement out, and then that will afford you a good level of fixation, then restore the tube with cables. And in this case, you can see that we've achieved a fixation over long length around the isthmus, and the tube has been restored, which is why we did not need a plate in addition to this. This is the curved Revitan stem. And the good thing about this stem, again, which is something to bear in mind when you have your revision inventory, is that on the larger sizes of this conical stem, you have distal locking options. So in cases where the isthmus is not giving you fixation, sometimes, or you have to go long on the 260 stems, sometimes that distal locking option gives you further security, especially in the elderly osteoporotic bull. This is another case of a B2 periprosthetic fracture. Now, in this case, as against the first one, the bone itself is not too bad, okay? But what is obvious is on both sides, this patient has a constrained hip replacement in situ. Okay? And that does pose a particular problem, i.e. normally approach to these fractures is fairly difficult because obviously the femur is broken, so you cannot rotate it. Plus the fact that it's got a constrained mechanism in place, you have to get access to the constrained mechanism. Okay. If we apply the same things that we talked about, this is a C-stem of the older design, and again, goes again with the taper slip thing. This is a B2 periprosthetic fracture. So options are, you could fix it, but unlikely to be successful because the implant is now unstable. You could revise and fix it with a similar length, but then plating it distally because the cortices look decent further down the line. What we opted to do in this case is frequently, especially when you have that lesser trochanteric split going up, it's quite worthwhile getting a CT scan to explore the bone stock available. But then we delivered the femur through the fracture site and then lifted it out of the constrained mechanism. Okay, this was the lateral, and the lateral looks fairly innocuous on that view. Our go-to stem is a long uncemented stem in these situations. If the patient can tolerate an operation that's long enough, and again, you can see that we've cleared most of the cement. There is still a thin sliver of cement around the lesser trochanter, but by and far you've restored the tube and then go back to a constrained mechanism. We did not have to do anything to the cup because that was well fixed. There is a compatibility issue. So if the head sizes don't match, i.e. if you don't have a 22 millimeter head, then you can run into problems. So that's the post-op X-ray. This is an interesting one. So this is, again, this would be distal to the stem, but what I'll bring your attention to is here, the cement extends a long way further. So this is the bit that I was talking about, that although you would consider this possibly as a type C fracture, it's actually a B2. Okay? The bone stock is okay. This is a young patient, 8 years after revision total replacement. You can see the acetabular augmentation that has been done. Rheumatoid arthritis, so spontaneous pain and collapse. So this is almost similar to atypical fractures or bisphosphonate fractures type of thing. The transverse fractures are the ones to be wary of. Okay? So the options again in this case would be to try and span this with a long uncemented implant. That would be a big undertaking. And in the literature, and certainly in the Vancouver group, the things that have failed are this sort of thing, that it is a B2 fracture or a B3 fracture, okay? Where the problem comes is that people identify this as a B1, fix it, and the fixation fails. Okay? Now, in this case, the implant really looks well fixed, but there is cement distal to it, and the fracture has gone through the cement. In this case, however, we opted to fix it as this patient already had 2 revision surgeries in the past. But this is where I come to the modern fixation devices, that you can fix these fractures, but you have to think about the fixation. So this is one of the Perilock plates that we have used in this scenario, but dual plating. So again, the teaching was that you put a strut graft anteriorly or posteriorly, and then you put a plate along it. We've replaced the strut graft with an additional plate, and that plate is used to compress the fracture, and then the long plate is just spanning the fixation. The good thing in this case is because the revision stem was an in-cement revision stem, it is quite small, so you could easily get these many screws across it. The key thing in this case is not to make the fixation too rigid. So just to show that that goes on to union at the fracture site, the patient does have arthritis in the knee, and what we do about it further down the line is a different story. Further x-rays of the same. So again, cemented stems. You will see that my practice is a significant nature of it is cemented stems, and that's what we do in Bristol in most cases. And that's why most of our periprosthetic fractures tend to be in cemented stems. This is the CPT stem, again, a taper slip design, and you've got a comminuted fracture, but this patient is 90. And he has a distal knee replacement. So the choices that we were thinking about is if you go with a long uncemented stem, the worry in this case would be that you would have to meticulously take all the cement out from the proximal, which would increase the length of the surgery, plus it will cause a stress riser in porotic bone, although his cortices look decent. So in this case, we chose to go with a long cemented stem, and this is the Exeter stem. Again, restored the tube, but the advantage of it was that the stress riser is distributed a bit, plus the fact that we didn't have to take all the cement out meant that we could get away with a quicker operation. As you can see from the date, this is a fairly recent fixation. We did not have to change the cup, did not have to supplement it with a plate. And contrary to what the popular belief is that the cement will extrude out of this sort of fracture site, that doesn't happen. Even though the fracture was quite comminuted, provided you restore the anatomy and make it a tube, there's not a lot of cement extrusion that happens, and certainly it doesn't seem to interfere with the fracture healing. And then there are times when things don't go to plan. So this is the sort of B1, B2 controversy. So similar fracture, but this is a much older case. You can see that it's a Charnley type stem with the transtrochanteric approach, and the fracture is transverse around the level of the tip of the stem with a distal knee replacement. So the choice was rightly made in that scenario, you could argue, in the first instance, to fix this. However, this is the old sort of Dalmals type of plate, and the sort of, now if you look at these x-rays, you would see that the distal fixation was never a problem. The tenuous fixation with this was proximal, and you only have 3 unicortical screws and 2 cables on that. The fracture side is not compressed. It's a single fixation device. There is no strut graft, no plate. There is still cement in the fracture side, which has not been cleared. Okay, so this, if I did this now, I would not be happy. And as you would expect, you have the walk off of the plate proximally, and the fixation failed. Then the choice was made to revise this to an uncemented stem. And at that time, it was a solution stem, which was a long uncemented monoblock. And unfortunately, that didn't go to plan either. Okay. So you can see that there is that anterior perforation. Because it's a single monoblock straight stem, it's not matching the curvature of the femur. They tried to sort of mend it together with cables. Again, not very well. And then the obvious failure. So what started with what was a fairly innocuous fracture has now caused a major issue. Because there's a distal knee replacement, your choice is limited. You can't go any longer. You could go with a tumor prosthesis and put some cement in, but then there is a risk of a further periprosthetic fracture at the junction of the knee and the hip. So this time the option was revise the stem, fix it with a plate, with cables and an allograft. And with that, we had some success, but then had a dislocation, which then meant we had to go on to constrained hip replacement. So this is 5 years down the line when this whole saga started. This patient finally has a functioning hip, but has had to go through a lot of surgery. Thankfully, did not get infected. So these are like with the whole adage about getting it right first time, try and do the first operation well, and that will stand you in good stead. This is just sort of almost by the by that certainly in distal Vancouver type C fractures, this was a publication that I found which was interesting, that somebody using the Phelos plate for distal femoral fractures. So the Vancouver type C fractures. So what they thought that the Phelos gives a configuration of about 8 to 9 screws that they can put around it. In my view, it's not robust enough, but certainly they seem to have got union in those fractures. And it's quite a good thing in areas, again, where there's been a big stress riser. So you've got a long stem proximally, you've got a knee replacement, and you need to get lots of screws in a sort of small, tiny area. I think the modern stems, the modern plating systems are very good, and they will allow you plenty of screw options. They're either staggered or there are flange plates that go out that will allow you to change your angle of fixation. This is a slightly different thing that we tend to talk about, having a multidisciplinary team approach. And like I said, it's not always possible. And the philosophy behind this is that the trauma surgeons are skilled at fixing fractures. They do it all the time. Arthroplasty surgeons are skilled at revision surgery. So if you work together, and certainly in our hospital, what we have, you have a trauma surgeon, a hip arthroplasty surgeon, a knee arthroplasty surgeon, and we review every single periprosthetic case, okay, and then decide the goals that we're going to achieve and how we're going to achieve it. And in quite a few cases, we operate these cases as combined cases, okay. If it's a straightforward revision or a straightforward fixation, then it's fine. But in quite a few cases, we do it together. So fix the fracture, and then you can get away with a smaller length of stem as against going into the distal femur. Always think about your next operation. Advantages of this is combined decision-making and operating. It's fun operating with colleagues. It takes the stress out of the situation. These are tricky cases to fix. It's useful in salvage of failed fixation. It has medical legal benefits. And then it definitely does reduce the operative time. Unfortunately, it's not applicable in all cases. In most cases, it's applicable certainly in the primary scenario, cemented stems. Revision scenario, definitely only cemented stems, because with the big uncemented stems that are used in revision surgery, you get very little space to put your screws, which are bicortical. You can put unicortical screws, but it doesn't really give you that much fixation. And so the actual procedure of traumaplasty, as we call it, is only applicable for the proximal femur, but the philosophy behind it is universal. And then there are some problems for the future. So you have a situation wherein, like I said, you've got just on the top of this sort of X-ray, you can see the distal tip of the stem coming through, and then you have a revision knee prosthesis. So your options in this are very limited, but this is going to be a problem for the future, that somebody has had revision hip replacements, revision knee replacements, and then in these cases, something like a sort of the Zimmer plates or the Periop type, the Smith and Nephew plating system is quite handy, that you span the whole bone, you get some fixation, but if you can get a dual plate fixation, that is ideal in these cases. Further down the line, if you can't get any fixation, or if there's any combination, unfortunately, the solution has to be a total femur. This is quite a good algorithm that I found, which we'll end on. So where we talked about comorbidities and the activity levels of the patient, and then using the Vancouver classification to substratify these cases. So you define the activity of the patient, you define the ASA score. If the activity is low and the ASA score is greater than 3, i.e. you're doing it mainly for pain relief, don't revise the prosthesis, just fix it with good plating systems, possibly dual plates if needs be. If the patient activity level is normal or high, and they are not as comorbid, then you think about the Vancouver classification and then deliver according to the bone stock. Okay. If the bone stock is low, younger patient, try and restore bone by either using allograft, which is now, like I said, we don't unfortunately keep allografts in the unit. We don't have a bone bank on site. So we don't tend to use allografts as commonly now. and we would straight away go with another dual plating system. But otherwise, what I would strongly advocate is revising the implant so as to give it either a new cement mantle or a new sort of bones implant fixation, but fixing the fracture so that you don't have to go long into the diaphysis. And that's certainly a philosophy that we are now pursuing. Obviously, we've formed a Southwest group which is looking into this, but we don't have the numbers yet to publish it. Thank you very much. I'll stop there.
Thank you very much, Sanchit. That was very systematic, very exhaustive, and I think it has laid down the path for Nikhil to show his, I would say, unusual cases, and it will cement the philosophy and the strategies which you have discussed. So before Nikhil shares the screen, I would ask my panel to come forth with any questions or any discussion points.
Sanchit, I have one question that you mentioned about using plates along with distal fitting stems. Where exactly would you use those plates? Both in cemented and uncemented, you mentioned both the option and use plates along with it. What makes you think of using a plate? Okay, here I got a distal fit, but I still want to use a plate. Could you tell us about that?
So where I have gone into the diaphysis, I probably won't use the plating systems. Like I said, that with the big porous coated cone conical, whatever design stem you use, there is very little place to allow for bicortical screws. It's where you want to try and preserve the diaphysis. So almost 3 centimeter fixation by and far distal is good enough with the modern stems. So I wouldn't use a plating system, but what we're going more and more towards is plating it and then revising it.
No, my question was, you had mentioned revision stem and plate in addition to the revision stem.
No, so like I said, I think that the revision stem, but not going as long.
No, okay. That will be giving you palpitations, won't it?
So I think we used to, unfortunately, especially where the great trochanter is separate, that's where we would fix the trochanter with a small plate and go with a long stem. But to fix it, to span the whole thing and a distal stem, it's impossible to get any screws past it. So I would agree that I wouldn't go put a plate there because we won't need it.
Sanchit, just one question I wanted to ask you. Very good presentation. You brought out most of the things which we face when we fix these difficult periprosthetic fractures and we have them during revision surgeries. Have you had a situation like many times when you're using a long uncemented stem and there's a bow mismatch which you brought out and we have to take care of it, try to neutralize it and try to use either a boat stem or bone preparation to match the bow so that you do not actually hit the anterior cortex. But have you faced a situation in which, since your stem and bow of the femur was not matching at all, you had to fix a periprosthetic fracture which happened on table in a manner to suit the canal? So kind of malalign the fracture to align the stem into the canal and plate it so that the stem tip now is not abutting, and or you in this situation you will just follow the native anatomy. I hope you understood what I'm trying to bring out, that to match the bone to the stem or stem to the bone, that kind of a situation at times which happens.
So one of the things that has been advocated for this, although I have to say that I've not had to use it, is when you have the extended trochanteric osteotomy type picture, what people tend to do is, rather than constructing a tube, so what we have had done in most cases is reconstruct, reduce the fracture, and then put the stem distally. But in those situations where you have a mismatch, you open the fracture, you almost convert into a sort of just a distal shaft. So the other side of the femur is divided. Okay, so you put the stem in, get the distal fixation, so you have a straight shot in it, and it's central within the canal. And then you oppose the proximal fragment, the ETO type of component, if you like, onto the femur, use a jiggly saw to divide the medial side of it, if it's not already broken, and then almost have the fixation in 2 bits. So most of these stems, so not the Revitan, but most of the other systems, so the striker stem can be used without proximal support. So you can get just a distal fixation and then get the sort of almost cobble the proximal femur around it with cables.
Yeah, bivalve.
Which may not be, approximated.
Exactly, which may not be approximated
because of the anatomy.
That's a good point, Vikas, and well covered, Sanchit. Any other points, Gurinder or Nikhil?
No, excellent presentation. So my thoughts are very similar to what Sanchit has said. It's quite uncanny that with time you sort of zone in on the philosophies that work and zone out the philosophies that don't work.
This concept of getting trauma colleagues is excellent, and this word traumaplasty is very appropriate. And in India, I've got a very low threshold of calling colleagues and having a safe pair of hands, whenever such situations arise. So I think Nikhil, you can share your presentation, and then we can have further discussion.
Can you see it?
Yes, we can.
Yeah, I completely agree. Operating with a colleague is very useful. It's one of the reasons I have not given up trauma yet, because of the periprosthetic and the acetabulum fractures as well. So I'll just reinforce the points that Sanchit has already made using some cases. You can hear me, right? So let's look at the distal end of the femur first. We have looked at the proximal end of the femur. This is a lady who has already had 2 or 3 revisions on her knee, and the latest revision was like a rotating hinge knee. And she had a trivial fall, and she's had a fracture which looks like this. So it's not exactly at the tip. So it's not the equivalent of a type C. It's more like the equivalent of a type B. The question to ask in these fractures is very similar to what we ask in the hip. Was the knee a happy knee? Was she happy with that knee, or was she not happy with that knee? In other words, was the prosthesis stable or not stable? Because that will decide whether you want to revise it or you want to try and fix it. So we find a CT scan quite helpful in these cases, because they show you quite nicely that the prosthesis is still well fixed. It also shows you that the long spiral fracture extends much beyond what you think you can see on the X-ray. So based on this, a decision was taken that I could probably fix it. So then what is important to understand is the principles of internal fixation. We all started off as trauma surgeons, but somewhere along the line, some of these principles get forgotten. And Sanchit showed a very nice case of a long plate. And I completely concur with that. So these are the questions that I tend to ask myself or teach the fellows when they're going to do a fixation of this type. Is your technique biological? Are you going to achieve a reduction respecting all the biological tissues? What is the length of your plate? And the concept now is you span the whole femur or as much of the femur as you can, wall-to-wall plating. That's what we call it. Get good zone or cluster of fixation in your distal fragment, and get a good zone or cluster of fixation in the proximal fragment. And ideally, the central fragment, you try and avoid putting any screws in it. And the reason for avoiding the central zone is to preserve the vascularity around the fractured area, and secondly, to avoid over stiffening of the construct. And then depending on the type of fracture, you decide whether you want relative stability or you want absolute stability. So this is what I did. And for this, planning is very important. You have to know the length of the plates available, the shape of the plate that is available, the type of screws that can go into it, whether it's titanium or stainless steel, where the flare is located, whether you're going to use locking screws, like in this case distally, or whether you're going to use non-locking, whether you're going to mix and match the screws, how many cerclages you're going to put, and where they're going to be placed. And what we do is actually we draw these images and diagrams on a piece of tracing paper, or if you have TraumaCAD or OrthoCAD, you can do the planning or you can do digital planning, and you can actually meticulously plan each fracture screw as well. So this was the fixation that was achieved. And what I like to do anteriorly is to put a strut graft. I'm not a big fan of the second plate because I've seen a lot of problems with the second plate. It often devascularizes the fracture and it causes a lot of stress shielding in the zone of the fracture. So I prefer to use strut grafts, and I've used about 22, 23 of these with a good long-term follow-up, and we are hoping to get it published soon. So this is what I tend to do, use a strut graft. We have it on the shelf, and there is a particular method by which I prepare the strut graft. And you can see at 5 years, the fracture has healed, the strut graft has healed, the prosthesis hasn't loosened, and she has excellent function. So let's look at another case where perhaps the fixation is not quite what we wanted based on the philosophy that we just saw. So I inherited this patient. He came from abroad. He had had a cemented hip replacement done in the UK, fell on holiday, had a fracture, and it was fixed with this type of plate. Now we can see, if we go back to the principles, we can see that it hasn't really followed the principles that we outlined. Is the technique biological? Not quite, because the fracture zone has been completely violated. Is the length of the plate appropriate? I think it's quite a short plate. There's not enough fixation in the distal fragment. There's not enough fixation in the proximal fragment. And the central zone has been violated by the use of these radiolucent bands, something like a Parham band or a Partridge bands or that sort of stuff. The construct is neither overstiff, but it's in fact, it's quite unstable. And so that's going to fail. And he came during the COVID crisis. So we discussed a lot of these options. What do we do? Do we revise the fixation, or do we revise it with a revision stem, or do we just go straight for a proximal femoral replacement? And we decided to try and preserve the proximal fragment if we can. A proximal femoral replacement is definitely technically a quicker and an easier option. But in a young person, when you do that, you eliminate all future possibilities of reconstruction. And when a proximal femoral replacement starts dislocating or it fractures below the tip, you have nothing left but a TFR. And if it gets infected, we've inherited some patients where the options have been a hip disarticulation. So my philosophy is to try and be as conservative as you can, try and save as much bone as you can. So this was the planning, the various different lengths of stems and plates, and you have to keep available everything on the shelf. So when I went in, unfortunately, the proximal femur, at least the 2 inches of bone below the lesser trochanter was completely dead. And it was also quite fragmented. But we had excluded infection. So I decided to preserve the tube as much as I can for the benefit of preserving the abductors. And this is what I did. A revision using a stem that was adequately long to get good distal fixation, an anterior strut, DBX and DBM, and tried to assemble the proximal tube as best as I can within the limitation of whatever bone was available. So see what has happened now at follow-up in about 3 months. The proximal femur has actually disintegrated because of the various fracture lines going through it. So the assembly of the tube has not worked very well, but the distal fixation has stayed very stable. So the patient is completely asymptomatic and he's mobilizing well, but we know that the proximal fragment is no longer gripped by the stem. And this is, I think, what Sanchit was trying to highlight. When you try and put a very bold stem into a femur that is straighter, you sort of wrap the proximal fragment around the stem, but then whether it functions or not becomes largely irrelevant. So long as the abductors are maintained, it is doing its job. So let's look at some of these cases. So we get a lot of these referred to us. So this was a cemented hip replacement. We are not quite sure what happened during surgery, but at some stage during the process of reaming and broaching, there was a big fracture, which unfortunately the surgeon did not realize. And he put cement into the femur to try and cement his stem. And when the cement started coming out of the fracture, that's when he realized that there was an intraoperative fracture. So thankfully, he did not put the stem in. This is the stage at which he called us. Surgery was abandoned and the patient was referred to us. So one of my colleagues did it. And again, we discussed all the options. You can see that there is quite a long 6 to 7 centimeters of cement column in the distal fragment. So the options are to try and put a hip replacement in after taking that cement column out, or to just put a hip replacement in whatever femur is available to try and get a quicker and perhaps a less invasive operation. And that was what was done. So this is an intermediate length AMT stem, which is about 170 millimeters, and it was just appropriate for whatever femur was left. And I thought this was quite a nice reconstruction, and the patient also did quite well. At 5 months, unfortunately, he had a very minor twist and he fractured exactly at the tip of the stem where the original stress riser was present. So now we are probably back to square one. We have the same problem again. We have a proximal femur that has a lot of cement in it, and we have a long cement column in the distal fragment. And now the options become a lot more difficult. So again, we discussed, what do we do now? Do we do a revision to a long stem, or do we try and fix it? So whatever option you have to do, that cement has to come out. And that's what I did. Took all the cement out, and I decided to go with the fixation because the proximal cemented stem is really well fixed. And my colleague mentioned that the proximal fragment also, if you try and take out all of that cement out from nearly 170 millimeters of a long cemented stem, it is probably going to cause a lot of destruction. And Sanchit mentioned this point as well. When you have so much cement to take out, and if the fracture can be fixed with sound principles of internal fixation, then fixation can work as a very good option. And again, I've used an anterior strut, and you can see at follow-up, what happens is there is a small fracture in the strut, but the fracture is showing signs of healing. So he's not through the woods yet. This is a relatively recent case. I think it is only about 3.5 months old, and he still remains under follow-up. He has started full weight bearing. So far, the progress has been positive. So I'll keep you posted about what happens over here. This was a revision that was done with an in-cement revision using a smaller and a shorter stem and a socket revision for wear. And this is a risk factor for periprosthetic fractures. So you can see that he has a long spiral periprosthetic fracture, but unfortunately, he has also taken out the trochanter. And these become quite difficult to try and fix. So my philosophy is to try and avoid putting any metal work on the trochanter unless the trochanter is connected to a long portion of the lateral proximal cortex of the shaft of the femur. So I don't like to put the hook plates on or cerclages, because what I found is the trochanter in these cases is often quite soft and it just disintegrates under the plate. For whatever reason, the infection risk is high and the outcomes are not really very good. So I tend to just ignore it, or to stitch it using a thick suture material, using some drill holes, or just wrap it around and try and keep the soft tissue sling intact of the abductors, the trochanter, and the vastus lateralis. And it does work. You don't often get radiological union, but you get firm fibrous union and with good abductor function. So this gentleman came for a follow-up just last week. I have a video of him walking, which unfortunately I've not been able to attach to the PowerPoint presentation, but he walks with a very slight limp, and the limp is actually coming from an arthritic knee, not from his abductors. So problems with an ETO. A lot of surgeons favor an ETO to take cement out or to take out uncemented stems. And I think in the past conclave meetings also, I have made this point. As far as possible, I will try and avoid doing an ETO. And I've got a collection of cases with problems related to an ETO. It is not at all a benign operation. It has a significant complication rate. Unfortunately, when we read our literature, we tend to get publication bias. So we tend to see the good papers of ETOs, but we tend not to see those where the complications have occurred. So this was a very well fixed, well ingrown, uncemented stem in a patient who was dislocating. And one of my colleagues did an ETO to revise it to a car stem. So this is a long choroid stem. You can see that, we talk about the principles of going to at least 2 cortical diameters beyond the ETO, which have been followed in this case. But what is important is to appreciate the stem design when we follow this principle. Now, the car stem, as you know, has got a slot in the distal portion of the stem. So the 2 cortical diameters rule doesn't quite apply to those stem designs where you don't get cylindrical fixation in the distal fragment. And the same problem happens with your modular stems, which are tapered and fluted. So the fixation is good, but I think the stem is a little bit short. And then within about 8 months, the fracture starts bending non-traumatically, and you can see that the stem is toggling distally and the whole fixation fails. Now this becomes quite a difficult revision because you've had an ETO, you've had a long uncemented stem, which is probably ingrown, and you have to try and put a stem in, and there's a knee replacement distally. And this case, I think I did this in 2011 or 2012 maybe. So the modern modular cone conical designs were not universally available. So the only interlocking stem I had at that time was a reef stem, and the sizes in the reef stem are limited. So it was either too short or too long. So I chose to go a little bit too long, almost up to the knee. The advantage of that in retrospect is that you don't get an interprosthetic fracture, hopefully. When I went in to take out the stem, despite the ETO, the stem was very solidly united medially. So the car stem had got very good ingrowth on the medial side. And surprisingly, the ETO was ununited. So as soon as I cut the wires, the ETO sprung open. But there was a lot of fragmentation medially in an attempt to take that stem out. So I had to use a strut graft. And again, the whole trochanter was attached to the proximal fragment. So I've tried to use a strut graft to try and get that to sit down with a lot of comminution. So over a period of 6.5 years, you can see what has happened. And I've seen this with a few patients now, where there has been an ETO or where there has been a lot of proximal comminution with or without a strut graft, and you use a long stem, the proximal femur slowly starts dissolving. The bone slowly disappears underneath the cerclage wires. And I think this is probably a combination of avascularity of the bone and stress shielding. But surprisingly, even though the proximal femur has completely defunctioned, the patient is functioning extremely well at 6.5 years. So that reef stem is now effectively working as a proximal femoral replacement. Another example of an uncemented LCS knee replacement in an elderly patient who has a DHS at the top for a hip fracture, and she fractures. Now her femur is extremely soft and extremely porotic. And you can imagine when you try and take out that LCS uncemented tibial component, it is going to cause a lot of damage to the tibia. So in this case, what I plan to do is a tibial tubercle osteotomy. It's not something that we do very often, but it is worth knowing the principles and the techniques of doing a TTO properly, using a step cut proximally, using a thick cortex, doing a very long TTO, and keeping your entire periosteal sleeve intact. So this was a technique I learned in Canada from my mentor there, Dr. Hugh Cameron, when I was working there. And that is the technique I use. You can see that the TTO goes really, really long. The mistake is to do a short TTO. That causes a lot of problems. And then you go for a long TTO, and I went for a distal femoral replacement with a collar that is coated with HA. So this is the Stanmore prosthesis, and a very long stem that goes beyond the TTO and gets good fixation. And that is the follow-up, and the patient's doing quite well. And the other problem, of course, is she also had a fused ankle. So you can see that you have a fairly rigid lever arm, and you have to really be careful with preoperative planning to do these cases. So this was another example of a very well-fixed Chanley stem with a transverse type fracture near the tip of the stem. And I think Sanchit showed one of these cases where they chose to fix it because it's quite traumatic sometimes to take that cement out from the fractured proximal femur. In this case, the surgeon, this case was done in another hospital. He chose to take the cement out and do a long uncemented stem, but unfortunately encountered some problems. You can see that the proximal femur is quite shattered now, quite comminuted, and it has been reconstructed with the help of the wires, but the lesser trochanteric fragment is separate and the greater trochanteric fragment is separate. Nevertheless, he got reasonably good fixation. Post-operatively, within a few months, the patient developed extensive heterotopic ossification. You can see that the hip joint is pretty much ankylosed. And paradoxically, the stem did not ingrow well. So the stem was left loose, but he was functioning because he had a very stiff hip and with not a very good mobility. Unfortunately, what happens is when you have a loose stem, it keeps toggling in the femur and the femur balloons out, and the next fracture happens at the tip of the stem. This was a non-traumatic fracture, which goes all the way to the proximal femur, and you've hardly got any distal femur left now. So this is really, you're in the territory where this is fairly extreme orthopedics. You have a lot of HO at the top. The exposure is going to be difficult. Infection is suspected but has to be excluded. So in this case also we discussed the various different options, and we thought that the proximal femur is unreconstructible. This was a CT scan that shows you the level of shortening that he has got, and you can see that the bone quality is quite poor. So in this case, what we have done is a proximal femoral replacement using a megaprosthesis, fixing it in the distal fragment. But because the distal fragment also had intrafragmental comminution, we have used some circlage to try and fix it and then cement it in. And then we coat the proximal fragment with cement loaded antibiotics, or you can have a silver coated prosthesis. And it has this little trochanteric plate. So what you tend to do is you leave a sliver of the greater trochanter if you can, and then apply it to the lateral part of the stem on the flare. And then you can put a little plate on it so that you can attach the trochanter with the abductors to the lateral part of the cortex so that you can get relatively good abductor mechanisms. And if you have any doubt, then you have to go for a dual mobility or a capture cup to try and get stability. And that's his follow-up at approximately 3 years. And he's doing quite well. You can see that the distal fragment is healed. Again, he's found some irritation callus and some ectopic bone, but he's functioning quite well. In fact, his mobility now, without the HO and with a well-fixed stem, is better than what it was after the first revision. And then Sanchit mentioned acetabulum cases. So these generally tend to come to us because we are also the regional pelvic and acetabular unit, and that's really my main focus of my practice. So I've just got one case as an example, just for people to refresh the principles, because we covered this extensively in the last conclave meeting in pelvic discontinuity. So this was a traumatic fracture of the acetabulum. And you can see that both the columns are involved. It's a transverse type fracture of configuration and fairly displaced. The principles in this case are fixation of the columns of the acetabulum using a Cocker-Langenbeck approach, using an anterior retrograde screw from the posterior column to fix your anterior column, and then revise it with a trabecular metal or an ultraporous type cup, a double plate at the back of the column, bone graft for the central floor, which is quite deficient in these cases. And you can see the anterior screw that has been passed from the retrograde. And she's coming on nearly to 6 to 7 years now of follow-up. So that's it really. Those were the cases that I had. And I hope that they illustrate the point that Sanchit made. I think I'm muted, Kiran.
No, we can hear you.
Yeah. I think Kiran is muted.
Yeah, Kiran is muted. He'll have to unmute himself. Kiran, you'll have to unmute yourself. I think I'll call him.
Narendra, why don't you start? Narendra, I think you can start the questions. Nikhil, that was fairly a decent collection of cases. I think some of them are very, very good. And I think if I can imagine, the tricky one actually is that transverse fracture with just handle the tip. I mean, that's the biggest set of complications that I've come across. And that's where I personally feel, I think both of you would agree, that a dual plane fixation really comes into place in there. And I mean, the strut graft, I think Sanchit is sort of moving away from strut graft, but something on the anterior aspect, whether you use metal, whether you use a lateral plate with something in the front, is almost like an essential requirement in there. And I think the original Vancouver people obviously talked about the strut graft because of the issues that Nikhil said about devascularization and the fact that you don't want to have a completely dead piece of bone in the front. So I think that's the one which is very complex, and very often people need to think hard about and go for the dual plate fixation, even with sometimes with a prosthesis inside.
It was quite reassuring to see some of those being fixed, because like one of the X-ray Nikhil showed, that the proximal fragment really shatters if it's just a transverse fracture and you try and take the stem out. The proximal fragment just sort of bursts into multiple bits. And you kind of think, have you achieved anything by doing that? Whether fixing it properly would have been better. And I think functionally, like you said, we are evidence one side, we are guided by the results. So I've had a couple of trochanteric escapes where there's this fracture going and the trochanter goes. It makes the X-ray look very bizarre. I agree the function is not as bad, but the aesthetic sense is quite clouded. We've favored certainly the claw plate, which I find quite useful, but I agree that it is a bulky thing.
The funny thing about the trochanter is, I mean, the blood supply is fairly good. There's a bulky muscle attached, but it just goes avascular so often. It just is the most annoying piece of bone for anybody fixing periprosthetic fractures. It just unbelievably just goes off.
So my philosophy on the trochanter has, to a large extent, been guided because we have been a trochanteric osteotomy unit for a primary hip replacement for the better part of 30, 40 years. And unfortunately, unless you are a really gifted surgeon, you have a 3% or more non-union rate of the trochanter. And sometimes up to 8%. And at least 1 to 2% of them are what we call as the flying trochanters. They just escape. And then these patients come back for follow-up at 30 years, 32 years, 34 years. If I see a follow-up of a Chanley stem that is less than 20 years, we always think maybe he was just having a bad day that day. So 30, 35 years, and the trochanter has been migrated and the patient's functioning nicely. Yes, some of them have a limb, some of them have an abductor lurch, but attempts to fix a trochanter, I have seen more problems with whatever method you want to fix than just ignoring it and leaving it alone. And that's why I've just sort of tried to leave them alone, try and put some thick ethibond or strong suture into it, pull it down, attach it to the abductors, and hope that it will get a firm fibrous union. And in the vast majority, that's what happens.
Agreed. I think, but the claw plate is definitely some sort of an improvement on that. But combine your claw plate with some cables which go through the plate is both really required.
So one or two of my colleagues like the claw plate, and that's what they use.
The other good thing which has come out is that clip which you put on to the plate. The one which allows you to. The spider, the one which goes front and back. That's such an interesting thing which Synthesis people made, which has been very, very useful.
We have it on the shelf, but I have not yet felt the need to use it. I think if you go long plate and with staggered holes, you can almost always get good fixation without the spider. My concept is to try and use the simplest possible construct that will do the job.
That makes so much sense. Sanchit, I know you raised this issue about removal of cement in the cemented component, especially in a Vancouver B. That's one thing which even when I'm revising the stem, I've never really been very pedantic. I said, look, some amount of cement in there. There will be a lot of my periprosthetics which are going to develop a fibrous union, but as Nikhil showed and as you showed, they will be functioning quite well. So that's why I don't really bother in my personal little series. I'm nothing compared to what you guys show, but I've never really bothered with meticulously removing the cement because for me, it just too much damage being caused by just knocking off that bit of cement. But that's just a personal take.
So I think you're right. Where it matters, I guess, is that if you do it through the fracture site, so if you engage the diaphysis with the stem, and then, like we said, wrap the proximal femur around, it doesn't matter whether you take the cement out because your fixation is distal.
Yes.
The problem I've found is that if you construct the tube and then try and do it from the top, then even bits of cement push you in a weird direction.
I agree.
And so the stem then goes, and then it's very near the anterior cortex, so you get a perforation. So that's when I tend to go sort of try and I actually put so some of those things, not necessarily more in infection surgery, but I put an arthroscope down to look at any cement bits once we've reconstructed it. So you get quite a good picture. You can see where the cement is and then fish it out.
Gentlemen, I lost the meeting for some time because the Zoom decided to upgrade itself in the middle.
Yeah, that's happened to me also.
So I want to thank Nikhil for his excellent collection of cases, which really, emphasized all the points Sanchit made. But one point I would like to discuss with all the panel and Nikhil and Sanchit is, they mentioned in a few cases the disappearing femur, and I've seen some cases where the grid blasted titanium stems were used, and actually the femur in these, especially in these implants, it actually reforms around these implants. So what are your thoughts about this, Nikhil and Sanchit, and in the panel?
So I think last time, in the last 2 or 3 conclaves, I showed some cases where the whole proximal femur has completely reformed. But I found that the femur disappears when you have a pre-existing ETO or excessive fragmentation, or where there has been a lot of devascularization. And I think the attempt to put cables to try and reconstruct the proximal tube probably adds to the devascularization. So in those cases, I think it disappears. In those cases where you have been able to leave it alone, so maybe for revisions that are not necessarily for periprosthetic fractures, but you just have a lot of osteolysis in the proximal femur and you have used a distal stem, but you haven't used any cables proximally, or where you have used some bone grafting. In those cases, I think it reforms. We have some remarkable X-rays of a very old prosthesis called the Roblewski proximal femoral replacement. We call it the BMW stem. It's just a very nicely designed cemented stem, which unfortunately DePuy don't make it anymore because we were the only users of the stem in the world. So it's not commercially viable. And in all of these cases, you can see the whole of the proximal femur has reformed. And it's not 1 or 2 cases, but dozens and dozens.
I mean, I remember one particular case where I used a bicontact distal locking stem, and where there was no sort of proximal femur when I actually went in. The patient had multiple surgeries, but eventually, after 7 to 8 years, there was some reformation. So I think it's the stem, the metallurgy and the design, and of course, if you leave it alone and don't fiddle around too much proximally, things can reform. So any other questions, comments, Vikas, Narinder?
I just want to mention about the claw plate, which was being mentioned. Where you really want to use it, those patients are not really fit for it. Those are the skinny ones, and that claw plate is really irritating. And that's where you really need the claw plate. The bulky ones normally do have a good bone stock, so you really don't need the claw plate. The skinny ones, where the trochanter has escaped, the claw plate will always be prominent. So that's kind of a problem with that implant.
So actually the one that Nikhil showed where the plate has failed, which was used to fix the periprosthetic fracture, that's quite a low profile plate in terms of the claw. Obviously not used in the right indication in Nikhil's cases, but that's kind of low profile for those patients. So I think that's the Smith and Nephew one.
A very useful technique is to take some strong Ticron or Ethibond type stitch and then weave it through the abductor mechanism superior to the trochanter, and then through drill holes in the trochanter, and then pull down the whole layer. Just like, you see hand surgeons very cleverly repairing these tendons beautifully with a weave stitch and all that. And that really works nicely for repairing the trochanter and bringing it down. So take the benefit of the tendon rather than just the bone.
So I just wanted to bring out few additional points, which Nikhil also just elucidated. First of all, when you're dealing with the trochanter, and what our philosophy has been to go it almost every time, we want to ensure that the trochanteric fragment is large enough. So it's like an ETO. When we are dealing with a fracture also, we want to create that kind of a segment which with a lot of soft tissue sitting on top. So the escape issue is almost non-existent because it gets pressed by the abductors and the vastus lateralis. And the only way we try to put it in place is using sutures. So we have been also doing the same as Nikhil brought out. We more and more use sutures and some wires at times drilling holes into the LT, getting that fragment to sit so that the abductors are aligned well. We are not focusing really into hardware fixation of the trochanters because we have had infection issues and issues of really losing bone in trying to fix bone to the host using robust hardwares like claw plates and the trochanteric fixation devices with GTR systems of Zimmer. So we have gradually been off that in trying to get the trochanter where to sit. We want to make sure that the trochanteric fragment is large enough. So creating an ETO which has a lot of soft tissue attachments and putting it where it was. For the Vancouver B fractures, one more point I wanted to bring out is when the stem is very well fixed and it's a cemented construct, and that is where it is very challenging that at that tip, there is hardly any biology because there is cement up, some cement down. And when you plate these fractures, usually you need dwell plating, or at least if you have the bone bank, then you can have a plate on the medial side, bone plate. But we also have removed some amount of cement on both sides, even at the tip of the stem, and try to stuff some graft in. That's what we have been trying to do to augment the biology there, because what really fails is the biology there. There's hardly any bone stock to recreate, and still the failure rates are high and plate needs to be fixed well. We have been using cables and unicortical periprosthetic, we call it the periprosthetic screws, which are blunt at the tip, so they're easier to use, and even attachment plates of synthesis, which we have used at times. But minimizing the hardware and improving the biology also is important in these fractures. Another point was as brought out, the cement removal. Now, what we really focus on is removing the cement from the distal tube, because proximally it may not be so important. Distally, even a small bit of cement can make you totally go off center, because as it is, the canal is very narrow, and your reaming, you won't realize that you are eccentrically reaming and gradually eating away one side of the cortex, especially you're not using the image to see the distal preparation. So distal cement really obstructs preparation of a uncemented construct, uncemented long stem. So these are a few points which I wanted to.
A very important point actually, because if you don't do that, then your entire fixation is compromised. So that's an important point.
And another thing was about using prophylactic cables. I think we need to be liberal about it. Whenever you start preparation, just put cable. Wherever you have a doubt, put a cable. I have seen even after a cable, when we are going to the immaculate fixation of distal stem, and especially in a spline stem, the spline of the stem ripping open the cortex and very poor porotic bone below your cable. So at times you need a cable distal also. When you feel, so just usually we just put one cable and start our prep. If in doubt, if porotic bone, it's not a bad idea to put another cable down with a small incision. Cables should be used liberally in these cases.
That's absolutely true. Amongst all of us, I think Nikhil is the only one who's got access to strut grafts. What about you, Sanchit, in your hospital?
Sanchit is mute.
So we have gone off partly because of availability. You can still request it. We don't have a bone bank on site. But what we've found out is Nikhil has access to strut grafts, but to try and shape it, and when you put the strut graft onto the surface of the femur, it actually occupies a bigger footprint than the plate itself. So I think the strut graft is still handy where, like I said, it's a big stem where you won't get screws, bicortical screws certainly, but if you have, sometimes the plate just gives you that much fixation. We've changed our practice significantly. I pretty much don't use an allograft at all now. I would use a second plate, partly due to availability, but partly due to the philosophy.
Okay. So I think that covers it. And Nikhil has to go for another meeting. And it's very kind of him to take out time and share his cases and experience. Thank you, Nikhil.
Thank you.
And Sanchit, thank you very much. Really systematic and very exhaustive. And we enjoyed both of your presentations, and for my panel to contribute as well. If there are no other points, then I would conclude this conclave till we meet next time. And Gurinder, please take care.
Yeah.
Okay. Thank you, Ashok. Thank you, OrthoTV.
Thank you.
Thank you very much. Is Ashok around? I think we'll leave the meeting. Probably Ashok will close it.
I think that will be better rather than waiting for it.
Thank you very much.